Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Great to see everyone today. I am going to give updates in two main areas that were presented at CROI, doxyPEP and HIV PrEP. For doxyPEP, we got some results, final results of a clinical trial, saw some data of impact of the use in clinical practice, and some preliminary data on antimicrobial resistance. So the first trial is the final results of ANRS, or the DoxyVax study, which was a randomized trial to prevent STIs in MSM on PrEP. It was done in France. This was a multi-center, 2x2 factorial randomized open label trial with the design shown here. And you may recall that we have heard the primary results of this study. At CROI last year, the study had been stopped shortly beforehand, and we learned that doxyPEP was effective in STI reduction, and that 4C Men-B, or the serogroup B meningococcal vaccine, brand name Bacterial, was effective at preventing gonorrhea. But subsequently, there was an audit of the study. Some of the gonorrhea endpoints had not been accurately captured, and so they went back to reanalyze those, and this is now the final study results. So the first endpoint is shown on the left, and that is the impact of doxyPEP, oral doxycycline post-exposure prophylaxis, on the time to first episode of syphilis or chlamydia. And what you can see is there was a very substantial reduction, 83% reduction in that outcome in the people taking doxyPEP. And when they looked separately at chlamydia and syphilis, there was a significant impact for both infections. On the right, you can see the table that summarizes the time to first gonorrhea infection. And there was actually a significant effect with doxyPEP as well, a 33% reduction. And there unfortunately was not with the vaccine. So it was a trend toward it. It was pretty close. It's still possible that there's a small effect of that. And there are several trials ongoing in the US that I think will answer that question more definitively. But unfortunately, the excitement we had around that last year is no longer there until we get more information. For people who acquired gonorrhea during the study, they also looked at tetracycline resistance among people on doxyPEP and not on doxyPEP. And what you can see, consistent with results of other studies, is that the proportion of those isolates that had high-level tetracycline resistance was lower in the group not taking doxyPEP, 12.5% compared to the group taking doxyPEP, where it was about 36%. All right, then we have some exciting data from San Francisco at both the clinic level and the population level about doxyPEP use. I'm going to show you two of those studies. In San Francisco, they were one of the earliest adopters of doxyPEP. The doxyPEP clinical trial stopped in May of 2022, and there were guidelines released in San Francisco in October or November of 2022 recommending doxy use for people who would have met criteria for the study, as well as broader encouragement of consideration of doxyPEP. So this study looked at doxyPEP use and STI endpoints in the population in San Francisco City Clinic, which is the municipal STI clinic there, and compared pre-doxyPEP outcomes to post-doxyPEP outcomes from the time they implemented it in the clinic. Compared STI test positivity, so this isn't prevalence overall, but just of everybody who got STI tests, what were the proportion who were positive among doxyPEP users versus non-users. And then they analyzed this in two different ways, looking at the pre versus post, and then that pre versus post difference in the two different groups. What you can see on the left is there was a very substantial reduction in chlamydia in clinical practice, a 90% reduction. And in early syphilis, there was also a reduction of about 56%. As you can see in the orange boxes on the right, there were also reductions in those outcomes in the people not using doxyPEP. And it's a little hard to know all of why that is, but the reductions were greater in the group taking doxyPEP. This looks at the gonorrhea outcomes in that same study, and what you see is a non-significant decrease in gonorrhea here, so from 11.2 to 8.6%. And there was another abstract presented from a different clinic in San Francisco that found the same thing, essentially, impact on chlamydia and syphilis, not on gonorrhea. Then this slide shows the analysis of a population level analysis. So now looking San Francisco entire citywide data, they did an ecological analysis to again look pre-post doxyPEP guidelines. Here they really focused just on the period of doxyPEP, the pre-period after the time when most of the COVID effects had stabilized out in their STI surveillance data. So ecological analysis, they did this as an interrupted time series. And interestingly, they estimated that at the endpoint of this analysis, there were already 3,700 people taking doxyPEP in San Francisco, which they estimated was about 20% of MSM and trans women in the city. And what you can see here shows the top trend line of what you would have expected based on the pre-doxyPEP patterns and what was actually observed in the post-doxyPEP period. There was a 50% decrease in chlamydia, not showing the data here, which was not seen among cisgender women. There was a 50% decrease in syphilis, again, pretty substantial. And there was not a decrease. In fact, there was a statistically significant increase in gonorrhea over that same time period. All right, so now we're turning towards antimicrobial resistance. With all of this doxyPEP use, certainly we have many concerns and open questions about the impact of doxyPEP on antimicrobial resistance in STI and other pathogens and the microbiome more broadly. So this is a study that used specimens obtained in the doxyPEP clinical trial. Those were rectal swabs that participants took at enrollment and at 6 months. And they did DNA and RNA metagenomic sequencing of samples from the participants who had the highest reported doxyPEP use, essentially where you'd be the most likely to see an impact, versus people who were in the standard of care group not taking doxyPEP. In the microbiome overall, bacterial diversity and the total bacterial abundance did not differ between doxyPEP and the standard of care arm. However, expression of tetracycline antimicrobial resistance genes did differ. What you can see in this box plot is on the very right side, that's the tetracycline resistance group that was significantly higher expression of those genes in the doxyPEP group at month 6 compared to the standard of care arm, which was not seen with other antibiotic classes. And they also looked at dose-dependent responses and in fact found that doxyPEP was associated with a dose-dependent increase in tetracycline antimicrobial resistance gene abundance. So this is not in specific bacteria. This is really just looking in all of the stuff from the colon. How many and how often did we find tetracycline antimicrobial resistance genes? So in summary, doxyPEP decreases STI rates in MSM and transgender women. We have more and more evidence of that. There's a very clear impact in chlamydia and syphilis, both in clinical trials and in practice, real-world data. However, the decreased gonorrhea risk that we've seen in 2 clinical trials has not been borne out in clinical practice data. Scale-up of doxyPEP occurred very quickly in San Francisco. There's high interest in the intervention. And doxyPEP use didn't appear to impact gut bacterial diversity over a short term, 6 months, but is associated with a dose-dependent increase in tetracycline AMR genes in the gut. The clinical significance and how this relates to longer-term use is unknown. All right, switching to PrEP, I just want to tell you briefly about a few novel formulations. I think it's exciting to know what is coming down the pipeline toward us, hopefully in the next several years. First, a weekly oral medication. This is a nucleoside reverse transcriptase translocation inhibitor that was studied in a phase 1 study. So human participants, healthy participants, just testing safety and PK/PD outcomes. What they found was it was safe and well tolerated, and the PK profile, which you can see in different doses on the right, really supported weekly or less frequent dosing. So we will hopefully have sometime an oral weekly or less often medication for PrEP. A longer acting injectable, also some phase 1 studies reported here, The approved cabotegravir formulation was changed in two ways for this study. One was making it longer lasting by adding a human hyaluronidase, and the second is a new ultra long acting CAB formulation. What they found, this was also well tolerated, and the curve you can see over there on the right goes all the way out to 52 weeks. So they concluded that this supported a dosing interval with the ultra long acting CAB of at least 4 months. So 3 times a year PrEP injections. And then longest lasting, there were some updates on a study from an annual TAF implant. This was done in cisgender women in Africa. It was the first in-human phase 1 study and followed outcomes out to 48 weeks. Unfortunately, the implant in its current form was not tolerated well. You can see the implant site reaction frequencies at the right, with the blue being 1 implant and the pink being 2 active implants. And 31% of women in the study needed it removed early because of lack of tolerance at a median of 19 weeks. And unfortunately, it also had lower than planned drug release. However, it's exciting. It's a concept. I think this product can be improved and hopefully will be refined over time to be better tolerated and more effective. Okay, and then I'll just finish, as we've talked about these exciting new formulations coming, with a reminder that we already have a very effective and very inexpensive method of PrEP with oral TDF-FTC. And this looked at an ecological study of the association between PrEP coverage at the state level and new diagnoses. So again, this is ecologic. There are many, many important factors that affect both PrEP coverage and HIV diagnoses, which this doesn't account for and just reflects. They estimated PrEP use based on commercial data sets and defined PrEP coverage as the number of PrEP users per 100 persons with indications for PrEP. On the left, you can see the PrEP use increase over time in that lighter blue line, and the yellowish brown line at the top shows viral suppression, which has increased slightly, but certainly not as much as we would like over that time period. And on the right are the PrEP coverage states put into quintiles, with the lowest quintile on the left, highest quintile on the right. And what you can see is in those higher quintiles of PrEP use, there was definitely a significant decrease in new HIV diagnoses as well over time. So some encouraging signs of public health impact of oral TDF-FTC use. All right, and that's all I have. Happy to hear any questions or reactions. Thank you.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.